Live, hello, Facebook Live, Tuesday, 5th of March, 2019, 7 p.m., 7:06 p.m. And we are live with consultant plastic surgeon Jonathan Stiano. That's me introducing myself with my Q&A. I've got some questions that I have had already in the last week, but if you have any questions that you want to ask, then feel free to ask them here and now, and I will do my best to answer them if I can. So we have got some questions which I've got on my preordained thingy here, which is, hi, my breast is very saggy. It's dropped that my nipples are nearly at the same level as my belly button. I don't want my breast lifted. I'd like to have implants fit in and the excess of the skin removed. I'm interested in implants that are very sturdy, not looking naturally. I want them to look like those of many adult film actresses, shall we say. Would that be possible, and how much would that cost, please? Okay, so we'll answer the question. Is that hair? It's on that side. Yeah, we have a hair issue. I'll go straight on. I'll be right. So, yes. So we have. I have replied to that with costs and what have you. But it's an interesting question because it's the whole issue of breasts, implants and lifts. Broadly speaking, the thing about a breast implant is it makes the breast big. Lift is that it lift and it makes the shape better. So an implant makes it bigger, a lift makes the shape better. So the thing is to say, look, what's the problem? Is it shape or is it size? Or is it size and shape? So this patient is saying the breast is very saggy, their nipples are nearly at the same level as their belly button. Whoa. So that is sounding like a lift to me. But it's an interesting point because this patient is saying they want their implants to look, their breasts to look not natural at all, and presumably bigger. If there is you can do a similar sort of thing to a lift with implants. So what implants do, or in terms, when you have saggy breasts, what you need is you've got too much skin. And there's two ways you can address that skin. You can either cut it out, which is doing a lift, or you can fill the volume with an implant to sort of take up the slack skin. And now a lot of people, like this patient, doesn't want a lift. To be honest, no one wants a lift, really. If you asked anyone, do they want a lift? No one wants a lift if they can avoid a lift, because a lift gives scarring, it gives complications, you have to move the nipple, and there's all sorts of problems associated potentially with a lift. So no one really wants one if they can avoid it. So often people say, look, can I avoid a lift? And I understand why they say that. Now, sometimes you can avoid a lift if you have got a bit of a sag to your breasts by taking up that slack skin with an implant. But it needs to be quite a big implant, number one. So if you don't want to be much bigger and you just want the shape of your breast better and you might happy being a little bit bigger but not much, that's not sounding like a good prospect. I'll be like, you know what? I think it's a lift. It's the shape, it's the sagginess you really need addressed. So it's a lift you really need. Whether or not you put an implant in is optional, sort of thing. You can combine an implant with a lift, but it does increase the complications. So if you're going to use a small implant, you'd be like, it's increasing your complication rate. You might want to just have a lift to start off with and see if you're happy with the volume. If you're not, you can have implants at a later date. Similarly, if you're like, I do not want the scars of a lift, I really don't want it, like this patient saying here, I don't want the scars of a lift, totally understand it. You could sometimes do implants without doing a lift, but two big butts. Big butts. I like big butts. So two big butts is, number one big butt is has to be a big implant. So if you don't want to be much bigger, it might not do the trick, because the implant is doing the same job as what the lift would have done. It's taking up the slack skin. So that's the one big but. It has to be a big implant. The other big but is that it is not going to be as good as doing a lift. If you need a lift, if your breast is sitting low, the best way to address that is with a lift. So you cannot get, it's a compromise. If you say, look, I don't want the scars of lift, I don't want the complications of lift, fair enough, I understand that. No one does. But if you don't have the scars and complications of a lift, and you're going to use implants, you're compromising the result, and you may not get as good a result. You may well get a good result in a bra. You may look okay in a bra, but out of a bra, your nipples might sit low, your breasts might sit low, and worst case, your implants will be up here and your breasts will be falling off it. I've got to say, so this is something you really need to do with a consultation, because it's hard to do with just like talking in words, saying, "Oh, my nipple, my breasts are the same like the size, same level of my belly button." But if your nipples are the same level of the belly button, I suspect it's not. It may well not be a goer. So some people, it's like not a goer for implants. Implants are only a goer if you're borderline. If you're borderline for a lift, you could say, okay, you're borderline for a lift. You want a big volume increase. You could just have implants on their own, but your nipples would still sit low. Your breast will be bigger, but the shape of your breast, if you're not happy with the position of your nipples, it will be the same. The position of your nipples will be the same, and you'd have to put the implants in to sit with the breast. So you have to put the implants in low when you do the surgery. It's difficult to, it's a fraught surgery to get right, because you have to put the implants with the breasts if your breasts are sitting low. And if you don't get the implants sitting low enough with the breasts, you end up with breasts, implants up here, breasts down there, oblong shaped breast. Doesn't look good. So it is a tricky one. I'm not sure if I've explained that properly, but it's a tricky one when people are borderline for a lifted implant. So you might be an option for a implants only. It sounds like you're not, if your nipples are truly at the level of your belly button. But if your nipples aren't quite that low and you want a big implant, you might have an option of just having implants. But you'd have to accept the limitations of that, which would mean the shape would maybe not be quite as nice as we would like. And sometimes when you do these cases, sometimes you need to do a lift later on as a second stage and say, look, it just doesn't look right. I need to do a lift. Sometimes you just say, look, you know what, I've avoided the scars. I look great in clothes. I look great in a bra. Out of a bra, you know what, I wish my nipple was a little bit higher. That's often the case. I just wish it's a little bit higher. But, we cannot lift the nipple if we're not making a scar around the nipple. So if you're just putting implants in, you can't lift the nipple. So it's interesting that they're saying they don't want to look natural. They want to look like a adult film actress. And so that actually is in favor of the implant only, because that would be a big, maybe an extra high profile, big implant. If you want that sort of look, which is actually in favor if you've got too much skin and sort of borderline for a lift. So that's actually quite a good candidate. As I say, if you want a small implant, it's just not going to take up that slack skin. That. Of course, people are commenting here. What's going on? Jade's, good evening. Good evening, Jade. Tracy, what is that, Tracy? Is that clapping? Or is that waving? Anyway, right back at you, Tracy, whatever it is. Tracy, Haley, Louise. Not sure. Assuming that's someone that maybe, is it? I'm not sure. I'm not looking at a bum lift, but why are there so many risks associated with this procedure? Jade, that's what we want. We want people who aren't actually looking for procedures, just asking for questions, helping me out. Jade, you're helping me out. I respect you for that. Good question. So basically, it's all a bit in disarray, the bum lift, or whatever you want to call it, bum buttock augmentation world at the moment. So it started off with implants. We started with implants, saying buttock implants, but they had problems with them. It's really, obviously you're sitting on your bum and things like that. So dislocation was a problem, bleeding was a problem, pain was a problem. And so implants fell out of favor, really, because it was not a great place to put an implant. You've got a huge muscle there, your gluteus maximus muscle. You either put it into the muscle or under the muscle. So it it was fraught with problems. Implants, so implants got a bit of a bad, like in same in the anywhere else in the body. If you get infection, things like that, you have to remove the implants. So implants fell out of favor a bit because we said, look, you're sitting on all the time. The implants are going to dislocate, they're going to move, and that's not a good result. So then we thought, oh, you know what? Well, then fat grafting came in. We thought fat grafting, fantastic, brilliant, that's great. Now, whenever I talk about fat grafting, I usually talk about it in the context of the breast, and I always make a point that it's usually low volume of fat grafting. I don't usually use a huge volume of fat to do it. Now, if you're going to do a buttock augmentation, you need quite a large volume of fat. And people were South America and other parts of the world, Brazil, things like that, they were really sort of proposing this quite high volume fat transfer using quite large volumes of fat. And I was looking at these people doing these presentations, thinking, big volumes of fat, augmenting the buttocks with fat transfer. I thought, this is fantastic. It's fat. It's your own body. None of this problems with implants. None of this problem with dislocation and infection and all this sort of stuff. It's a great idea. Fat grafting. It's your own fat. Fantastic. Taken out from somewhere else. Brilliant situation. That's fantastic. But then what happened was lots of people died, basically, and people are continuing to die because the problem with fat grafting to the buttock is that there's quite a lot of large vessels, large veins, large blood vessels in the buttock, because there's big muscles, and those big muscles need blood because to work, and so there's large blood vessels in the area. And when you're injecting the fat, if you inject the fat into a blood vessel, if you inject a lot of fat, if you're injecting large volumes of fat, and if you inject large volumes into a blood vessel, the fat goes into it. It's called a fat embolus. The fat then sort of travels around your body and usually gets stuck in your lungs and basically clogs things up around your heart and lungs, and you die. You can die, and people have died. Young fit people have died having fat grafting, and it's been sort of way higher mortality than any other cosmetic procedure. And so there's been a lot of alarm bells ringing around with it. And BARPS, the Plastic Surgery Association, BAAPS, last year said that plastic surgeons, BARPS members, are advised not to do fat grafting to the buttock. So that the big problem with fat grafting was death, and so that was stopped last year amongst BARPS members. And now you see people now talking about implants again. Implants are coming back, saying, "Oh, implants actually are not so bad after all. At least you're not going to die." So they're coming back. And we're all running around thinking, is fat grafting safe if we do it properly? And do we need to make sure that people are trained properly to put it in the right layers and avoid these vessels? Then it can be done safely. And some plastic surgeons are saying it's a safe thing to do and we shouldn't really ban it. And it's all in disarray at the moment, but it is something that has had mortality associated with it. So it's a difficult area, Jade. That's why I've never done it. And it's a difficult area. And if you want it, look for someone who does a lot of it. In this country, not many people, I don't think, have embraced it. There's people in Brazil and in South America and things who've done huge. France, there's a guy in France, done huge numbers, huge experience, great results as well. So, but I don't think anyone in this country really, as far as I know, has really embraced it. But it is, and it's fraught with controversy. But at the moment, fat grafting is sort of out. Implants, well, I saw a guy from France, presenter, a guy from Paris, Francois Petit, do a fantastic presentation with some fantastic results with implants. Really, really good results with implants. So it's just like what's good with that surgeon and what surgeons are comfortable doing. What's the recovery time on Natalie? What's the recovery time on a mini lift? So breast lift. This is presumably. So yeah, I know what you mean by a mini lift, Natalie. Basically, a lift is a lift, and the problem with a lift is the scarring, and the problem with the scarring of a lift is there's two. It's when you get a junction of scars, you get problems with the healing. So you got a circle around the nipple, then you got a straight line. Now, so you always have a circle around the nipple. In my hands, if you're doing a lift, I would say you pretty much always have a straight line going down, and sometimes you have a line in the fold as well. So you have a circle down, so lollipop always, sometimes small t. So a small extension down there, like a little anchor. So it's the T's that are the problem. So if you have a circle and line, the lollipop, there's less T's. There's only one T, only one junction from the circle to there. So a small lift might be a mini lift might only have that one junction. And that is where the healing issues are. So you'd hope for it to be healed in a week or so, but you need to be taking it easy for the first couple of weeks. You won't want to be doing too much tension on that. So I don't know if you do the gym and stuff like that. Oh, I think you do the gym, don't you? So you don't really want to be doing too much craziness in the gym. So you've got to be careful with that the first couple of weeks. After a couple of weeks, you'll be getting back into gentle things, but not upper body stuff, lower body stuff. And it's about 6 weeks. To be honest with you, Natalie, it's similar to a normal, a full lift. I normally say 4 to 6 weeks for getting back to the gym. I guess maybe a bit less, but probably more like the 4 week than the 6 week mark, I suppose, for a mini lift. But it's still, moving nipples and things like that. But actually, 4 weeks. Should we say 2 weeks? 2 weeks light activities, 4 weeks. Yeah, 4 weeks to strenuous stuff, and then just start the strenuous stuff. I know what you like. Don't go crazy into some full on sort of big weightlifting thing. Just sort of start easy and start gently and then build up. Oh my god, the chat's going off here. It's kicking off. Oh my god, it's a wave / hello. Oh right, it's a wave. I'll tell you what, it doesn't. Is that a wave / hello? Okay, take your word for it, Tracy. Doesn't it looks? I don't know what it looks like. Looks like Well, let's let the people decide. Right, people, what do you say about that? Is that a wave / hello? Not familiar with that emoji, but I'll have to brush up on it. I'll get my Emojipedia out and I will check that up at my leisure later on. Cats in the house. Can skin be removed near the underarm bra line at the same time as a breast lift? Yeah. Yep. So this cat sounds like the sort of thing you might be thinking about doing for people who have lost a lot of weight. So people who lost a lot of weight, got a lot of skin, obviously got a lot of skin in the breast, but you can have a lot of skin here in the bit that you're already describing. Obviously, my jumper is sort of in the way, but yeah, sort of, I know what you mean, sort of extending over laterally, and so you can extend the excision to remove that excess skin in that underarm area. Sometimes people will do something called an auto augmentation, where they'll actually take that excess fat and keep it attached and put it back into the breast to augment the breast, make the breast bigger, but without using an implant, using that bit of tissue. I won't say that bit of skin, because you remove the skin and throw the skin away, but use the sort of the excess subcutaneous tissue there and put it back in. But maybe I'm going off topic, but your question is yes, you can. So you obviously have a lift scar circle around the nipple down, and the more skin you got to remove, the more scarring you get. So that's why the mini lift, you might be getting away with a lollipop if you've got a lot of excess skin. So I don't know what your situation is, Kat, but what you're describing is more someone who's got lost a lot of weight, breasts are sitting very low, they've got a lot of extra skin. So the more skin you've got, the more scarring you're going to get. So you're probably going to get a full anchor scar with that. So a scar going in the fold, which would then extend round to the side, as far as the skin that you want to remove, basically. So the scar goes as far as the skin that you want to remove. So it would be an extended scar, more healing and issues and what have you, but definitely something that can be done at the same time as a breast lift. Cat, good question. Big up yourself. Right, Emma in the house. Can you tell me if you have Allergan implants, if you go back to the surgeon who did them and ask them to do tests as you are having pain, do they have to help you 6 years later? Also, what happens if they are bottoming out after 6 years? Is this expected? Okay, Emma, if you have Allergan, right. So basically, I think the issue here is that Allergan are no longer available on the market. So what happened was their CE mark, which is their European sort of approval to be sold in Europe thing, they didn't renew it. They didn't renew their CE mark, so therefore they are not selling them in Europe. including UK, because of that. They didn't do any sort of recall or anything like that. So they didn't, there's no evidence that there's anything wrong with Allergan implants. There is I don't know what, Allergan are just saying, look, we're not renewing it. Now, there's a lot of things about this ALCL, this type of cancer associated with implants, which is associated more with not more, it's associated with textured implants. There's no smooth implants, people with smooth implants with this ALCL. It's a very rare cancer, but there are there was quite a few associated with Allergan implants, and so whether it's associated with the ALCL and the texturing of the Allergan implants, whether that's the reason they've not renewed their CE mark, that's the sort of speculation. I don't know if they've said that or not. I don't know if they, but that's what sort of people are talking about. Is but even so, the risk of ALCL is very, very low, even with Allergan implants, and the advice is not to do anything if you have Allergan implants in terms of changing the implants or removing them or getting new implants. The result is the advice is they are fine and they are safe. But with anyone with implants, you've got to look out for stuff, including stuff like ALCL, because that can happen with anyone with textured implants. So so you're 6 years down the line. So ALCL, 8 to 10 years is sort of classic sort of time it would appear. Usually it presents as a lump or a swelling. So if you get a lump or a swelling, you need to get it checked out. As I say, any make of implants, I wouldn't be particularly thinking, oh, alarm bells, it's Allergan, although I understand that you would be worried because of this, the fact that they're no longer available. But as I say, the advice is that they're fine to leave. But what you're saying, if you go back to you're having pain, do they have to help you 6 years later? Right. Well, I'll tell you my experience of this. It's hard for, so Emma, do they have to help you? No, I don't think anyone sort of, oh, that sounds harsh, doesn't it? God. Basically, everyone's different in terms of follow up and what they'll do and whether how they'll see you and what have you. I think you'll find that most surgeons would the way you're asking the question makes it sound like they're not helping you, but most surgeons, I think, would be happy to help people. I think most of us are happy to help people. But I'm going to tell you where I would go if someone came back to me with pain at 6 years. I didn't use Allergan. Well, I have used literally a couple of Allergan. I haven't used a huge amount of Allergan, but even so, whatever implant, I'd see them and talk to them. The thing about breast pain is, the thing you've got to think about with breast pain is it the breast or is it the implant? As far as you can tell, as you, as in probably me, really, not you, as in the doctor. What if someone comes to me with breast pain? I'm trying to get a handle as, is it the implant or is it the breast? Because obviously you've got an implant, then your breast on top. Is the pain associated with the implant or is it the breast? It's unusual to have breast pain due to an implant at 6 years. Now, that doesn't mean it's not due to the implant. I'm just saying it's unusual. You do get people with pain associated with implants, discomfort associated with implants, which can last a long time, particularly with the polyurethane implants. It can last a year or so for it to settle, but that's usually pain from the op sort of thing, unless you've had pain for the last 6 years. But, if it's a new sort of thing, it's unusual, but not necessarily unheard of. It could be associated with capsular contracture, in which case your implant will be quite hard. So if your implant's quite hard and it's painful, that's a different story. That's probably the capsular contracture causing the pain. That is not unusual, and that might be occurring at 6 years. Again, 6 years is quite early for capsular contracture, but that might be something. So the first thing I would be thinking about is, is it related to the implant? Is it capsular contracture? Has that implant gone hard? Is that what's causing the pain? Or is the implant lovely and soft? There's no evidence of any pain around the implant, and it's a pain in the breast. If it's a pain in the breast, then I would be saying to you, look, you probably need to see a breast surgeon. It always gets a bit confusing when I say that to people, because they say, well, I thought you did breast, I thought you were a breast surgeon, because I pretty much only do breast. But there are different people who do breast. There's breast surgeons who are usually trained as general surgeons, and there's plastic surgeons. And plastic surgeons tend to do the reconstruction. So, and breast surgeons deal with things like breast pain, breast lumps, breast cancer, and all that sort of thing. So if you have a breast lump, you go to a breast surgeon, not a plastic surgeon. You don't come to me if you've got a breast lump. You go to a breast surgeon. They'll do investigations and biopsies and what have you. If you need to have the breast lump removed, perish their thought. If you need a mastectomy or something like that, that will be a breast surgeon, not a plastic surgeon. If you need a reconstruction, then you come to a plastic surgeon, although often the breast surgeons do the reconstruction themselves nowadays. But if you're having breast pain in the breast tissue, then that would probably be a breast surgeon that you would be better off seeing, because that could be due to all sorts of things, hormonal things and what have you. And that would be so. And what I would say to you, if you were my patient, I would say, look, come back and let's see if it's related to your implant, because if it's related to your implant, I can help you with that. If it's a capsular contracture, or if there's a problem with the implant, I can help you with that. If it's breast pain due to the breast tissue, you'd be better off going to a breast surgeon. And to be honest with you, the NHS tends to treat this well. So I would actually say to you, look, you know what, I'm going to write to your GP and suggest your GP refers you to a breast surgeon, because they've got very good systems now for dealing with breast pain. Obviously, we worry about breast cancer and things like that. It's such a common thing. Any problems with the breast, the NHS has got quite good sort of systems in place to deal with those things. So that's where I would be going. I would be saying, look, if it's breast pain with the breast tissue, then your GP might be a better port of call, and I'll be referring you to the GP. So if your surgeon isn't helping you, which is, I'm getting the flavor of that with your question, then maybe go and see your GP. The problem if you go and see the GP and you say you've got breast implants in, they might say, oh, well, have you had them checked by the surgeon? Because it's probably your implants. So it's often nice to come to see me first, because I can say, yes, it's your implants are fine. Then I can write to your GP and say, look, the implants are fine. It's to do with the breasts. So yeah, that's where I'd be going. Also, what happens if they are bottoming out after 6 years? Is this expected? No, Emma, it's not expected, but it can happen. Bad things can happen. Bottoming out can happen. Depends on what's happening in your life and your weight and your situation. If you had children, things like that. The breasts can droop, the implants can bottom out, which is the implant descending below the inframammary fold. It's not expected, Emma, but things can happen. And so I wouldn't say it's expected. No, it's not expected, but yeah. And I would have thought, to be honest with you, Emma, I would have thought your surgeon would probably help you out. Most of us will help people out. We don't want to have unhappy patients, and if you've got a problem at 6 years, you would have hoped your original surgeon would see. And you bet your original surgeon's always your best port of call, because they know what they've done and they know what's going on and what implants they've done and how they've done it and what have you. And I would have thought they'd be happy to see you and help you out and give you reassurance or do whatever needs to be done. Nikki says it's a wave, so Nikki knows her emojis. She can go back to the emoji. Kat says, yep, huge weight loss. Yeah. So that's, yeah. So that's the extended breast lift going around the side, huge weight loss. Yeah. So extra skin. Debbie, hi, everyone. What's the best and safest, Debbie? What's the best and safest type of liposuction for the back area to achieve an hourglass effect? An hourglass effect. You know what, Debbie? If someone tries to tell you what the best is, I don't know, you've got to be a bit. The thing about liposuction, there's loads of different liposuction ways of doing liposuction. So therefore, there's no best. If there was a best, we'd all do that, wouldn't we? Who would do the non-best thing? We'd all do the best one. We all want to do the best one. No one wants, do you want the best one or do you want the other one? Well, have the best one, Answer, no best one. Basically, there's a range. And the range starts with non-surgical stuff, the freezing, the heating, the radio frequency, the cooling ones, the cryolipolysis, the whatever, the non-surgical things. So you go, you walk in, you have this machine put on, it freezes or heats or delivers energy to the fat somehow, which kills the fat. The principle being the fat is more susceptible to being killed than the skin. So it'll deliver a energy that will kill the fat, but not the skin. And then that will get rid of the fat. So that's the sort of least invasive. And then you move on, and then the other end of the spectrum is liposuction, full on. Well, okay, we'll stick with liposuction. It is liposuction, full on liposuction, sort of liposuction I do, which is power assisted liposuction, theatre, general anesthetic, tube goes in, sucks the fat out, very effective. But you say, what's the safest? Often needs a general anesthetic. If you're having it on the back, then you're prone, you're lying on the front, which isn't great for a general anesthetic. Quite big, quite traumatic, battered and bruised, all these sorts of things, but a very effective thing. So one end of the spectrum, you've got your non-surgical machine that just sticks on and causes a bit of discomfort, but nothing. That's probably the safest. At the other end of the spectrum, you've got your general anesthetic with someone sticking a tube in, sucking the fat out. That's not as safe as not having the other one, but the results are different. You know, the results of sticking a tube in and sucking the fat out is often more of a result. Otherwise, no one would have anyone stuck a tube. We would never stick tubes in if we didn't have to. And then in the middle, you've got your assisted forms of liposuction. Liposuction assisted with ultrasound, like Vaser, or ultrasound, or a laser assisted liposuction, and they deliver energy to the fat. There's still liposuction, so you still stick something in. So it's still a surgical procedure, but it delivers energy to the fat in the forms of ultrasound or laser to sort of destroy or heat up the fat before you suck it out. So you use a smaller cannula. You often need to use. You can do those under under local sedation often, because they're less traumatic because the cannula is smaller and it's delivered some energy to the fat first before you remove the fat. So that's sort of in the middle. So I'm sorry, Debbie, there isn't a best one. You know, they're people. It's about seeing a. I always say to people, look, choose a surgeon rather than a procedure, because just find someone who does what. You'll find that some people do a lot of one and a lot of the other, and if they've got good results with the thing that they do, then you just got to be happy with the sort of result you can get versus the sort of complications. So I guess the safest thing is to do nothing. That's really safe. No complications then. The next safest thing is to do the non-surgical thing. But then the results are less. It can be quite expensive. So you've got to move up safest versus most result balance. Adele says, would you? Would I, Adele? Would you, Adele? I'm gonna turn that back on you. Would you? Would you? 2-word question. Would you? I would, Adele. Yeah, I would. Yeah. So, Jade, what's the procedure? What's the procedure your clinic surgeons perform? The most, I meant. Sorry. Okay. You know what? Numbers wise, I think numbers wise, we do a lot of mole, cysts, local anesthetic procedures in the clinic, tattoo removals, sort of moles and cysts, lumps and bumps. Do a lot of those. General cases, breast augmentation. It's probably breast augmentation, followed by tummy tucks, followed by breast reductions and lifts. Yeah, but so breast augmentation for the GA work, but we do quite a lot of local anesthetics work as well. Oh, Adele's back in with a longer question. Would you recommend a polyurethane foam implant or silicone implant? Oh, Adele, I just tell people what exists. And it's a bit like the liposuction. Non-surgical liposuction exists, surgical liposuction exists. If one was better, we'd all do that one. So it's not like the one is better. And I wouldn't like, and sometimes people come and say, oh, can I have these implants, whatever it is, some make of implants, because they're the best, aren't they? These ones. And I'm like, there's no best. They're all different. There's good. Certainly when it comes to silicone implants, there's loads of different makes, and there's some big companies. Used to be Allergan, but Allergan not anymore. But Mentor, Nagor, Polytech makes silicone implants. There's some big companies. Sebin, Sebin, whatever you want to say it. What else? But then anyway, there's big companies that make silicone implants. And they're all different. Usually it's a warranty that's different. Sometimes the texturing is a bit different, the way they do the texturing. But broadly speaking, you couldn't really tell the difference. I don't think there's a huge amount to separate between them. But between polyurethane and silicone, there is a tangible difference between those two. And there's pros and cons, Adele. And I just say to people, look, this is polyurethane, this is silicone. Polyurethane is good because it is much less likely to go hard. So you're much less likely to have need operations in the future. But they're more expensive. You can sometimes feel the edges. They feel firmer than silicone implants. They can take a while to settle. They can take a year or so to settle. And years ago, they did an experiment when they injected they injected some stuff from the polyurethane implants into rats, and the rats got cancer. So a lot of people say, flipping heck, you're not putting those ones in me, you madman. I'm not having them. And I'm like, okay, fine. Well, let's do silicone ones then. And if you do get a capsule contracture, you can have polyurethane ones later on down the line. Now there's, I just tell everyone the pros and cons of them. There's good and bad about polyurethane. There's good and bad about silicone. I do like polyurethane. I've got to be honest. I don't want people coming back in 5 or 10 years to have their implants changed if I can avoid it. And I think long term they are good. But if you want to have silicone first, and then if they do go hard 5 or 10 years down the line, have polyurethane, then that's perfectly reasonable. I used to do that, and I think a lot of surgeons do that. They don't often offer polyurethane as a primary breast augmentation. They'll only use it for revisions. But as I say, I do offer it for primary. But so I don't particularly recommend Adele. I don't say you're better off having a polyurethane one or you're better off having a silicone one. I just say, look, these are the pros and cons of polyurethane and silicone. Go and do a bit of research. I'll give you some information. Have a think, see what you think, ask me some questions, and try and make a decision for you. Informed consent. That's what it is these days, Adele. It's informed consent. You got to sign the form, not me. Well, actually, I have got to sign the form as well. But anyway, that's different. You've got to sign your bit of the form. So, as in the consent form. Yeah. Right. Emma's back in. Thanks very much for taking time out of your busy day to answer my question. You've been very helpful. What was your question, Emma? I forgot what it was. Oh, yeah, Allergan implants. Yeah, okay, good. Oh, thanks, Emma. That's kind of you. Yeah. Well, good luck, Emma, and I hope your surgeon's being helpful, because your question suggested being helpful, but I hope they are. But good luck with that. And if they're not, go to GP. GP might be helpful, but you probably would want to get someone to check your implants. Nikki, what's your opinion on mega lipo? That's something on Godzilla, is it? Mega lipo? If the surgeon's very, very experienced. Mega lipo. What's my experience of mega lipo? I haven't got, well, what's my opinion on it? Well, I'll tell you my experience of it. My experience of it is not huge. I'm not very, very experienced on mega lipo, Nikki. I'm not big on mega lipo. Mega lipo, so that's a lot of lipo. I mean, it depends on what you're talking about. Mega lipo for me, you're looking at like more than 5 liters. So I think more than 5 liters of liposuction is a lot of liposuction, and it can be done. And there are surgeons who are very experienced in it and will do it. But you've got to be careful. You've got to, I think it's good to stay overnight, because it's good to be monitored, because you get fluid shifts after having such a lot of fat being removed, and you can get fluid shifts, and you can become hypotensive. Your blood pressure can drop. You can feel weak and dizzy. So it's good to have sort of a drip going on. And I would say it's good to be monitored overnight. It can be done, and I think if your surgeon, like I said, choose your surgeon, not the procedure. If your surgeon's experienced in it, and you've got a lot of areas that need to be addressed, and you get them all addressed in one go, great, go for it. But it is, it's a mega thing. So yeah, as I say, I it's not something I do. I don't do huge volumes like 5 liters plus, but it can be done. But if you are doing it, you've got to have an experienced surgeon. You've got to have a good facility you do it in. You've got to have good post-op care, because you've got to make sure that you're okay and stable hemodynamically with your blood pressure and what have you afterwards. So yeah, it's a thing, Nikki. And if your surgeon's experienced, go for it. Rachel, hi JJ. Would you say combined surgery is dangerous, considered how long you are under anaesthetic? Well, you don't want to be too what's the word, like creating an alarm sort of thing by using terms dangerous. But since you've used the term dangerous, I mean, it is more dangerous than having a longer anesthetic is more dangerous than a short anesthetic. But having said that, anesthetics are very safe these days, and when you talk to anaesthetists, it's a bit like an aeroplane. The danger of an aeroplane is when you take off and landing. That's the sort of danger time for an aeroplane, and the sort of cruising bit in the middle is less dangerous. And it's sort of similar for an anesthetic. The danger time for an anesthetic is the sort of induction and the sort of recovery. So it's not proportionately dangerous, if you see what I mean. So you could argue that if you're going to have, like, I don't know, a breast lift and a tummy tuck, say, it is safer to have it in one op, than having 2 general anesthetics, because you've then got 2 inductions and recoveries, 2 lots, as opposed to 1. So, but a longer anesthetic is, it is more dangerous. You have more anesthetic in you for that time. So the recovery, you can feel more jaded, you feel knocked back. It is a big thing having a combined surgery, and you have to talk to patients about, again, the pros and cons of having it combined or having it separate. So there are pros of having it combined. One, lot of recovery, it's cheaper because you just have one operating theatre, one set is opened, and you can use the same instruments and stuff. If you have a second operation, you have to open it all again. So there's cost savings with having it as a combined procedure. And I think a lot of people don't want to have time off work and things like that. So they want to have one lot of time off work. They want to get their recovery over with. You could get complications with either areas, because you've got two areas being operated on, but they're both recovering at the same time, like in parallel. Yeah, rather than series, they're both recovering at the same time. So if you got a bit of wound healing there and a bit of wound healing there, you sort of like, it's just getting it all done in one go, rather than getting one done and then 3 to 6 months later having the other one done. But it's difficult. I mean, I think it's difficult to know whether it's what's right for you. So if you purely saying, is it more dangerous having a longer operation than a shorter one, then yes, it is. But if you're going to need that length of time in theatre anyway, so if you're going to have a breast lift and a tummy tuck, so 3 hours now and then 3 hours in 6 months, it might be better having 6 hours now, if that makes sense. So yeah. So nothing simple, Rachel. Nothing simple. You want a simple answer? You ain't getting it here. All right, it's not simple. But yeah, I hope that's not trying to dodge it, but you got to think about pros and cons. That's what we're all about. So the clinic, that's what the consultation is all about, really. All surgery's pros and cons, and it's like, look, these are the cons. There's all cons of surgery, but there's also pros. And if the cons are too much, then don't have it. Don't have a combined one. Don't have surgery at all, sort of thing. Don't want to sort of do people out of work. Does it look very dark? Dark. Middle of the night. It's dark outside, I suppose. Big smiley face, Rachel, Nikki. Thanks very much. Loved you saying mega lipo. Yeah, mega lipo. Is mega lipo a thing, Nikki? I like them. Would you have that on an operating list? Mega lipo. Yes, would be a few days in hospital. Yeah, there you go. A few days in hospital. They'll look after you. There you go. Thank you. I should have been more specific. No, Rachel. No, you were not Pacific. You were Pacific enough. No, it's fine. No, I think the point is well made. You don't want to be too specific. Yeah. So that's right. So, oh dear. Right, here we go. And now we have got a question here. Are B-Lite implants? As I know, you have used B-Lites before. Oh, sorry, I'm not. I have chosen high-profile textured B-Lite implants 440. My mental high-profile implants were 375, 350. Are they any different to put in, and what are your thoughts on them? I think if you think about it, there's been a couple of there's a couple of sort of revolutionary things in breast implants. If you're sort of saying what are the big differences in breast implants, and I think the big differences in breast implants are polyurethane. I think that's a big difference. People try and make lots of little different and make their implants sound better because they've got some different texturing or some shapes a bit different, and they've got two types of gel, or all these little things that everyone's trying to find an edge. But I don't think there's any significant edge. I think the two big edges are polyurethane implants. I think that's a big deal, and I think the B-Lite implants is a big deal. I think the B-Lite implants is my thoughts on them. I think the concept is very good and very sound, and I think it is a big deal for breast implants, because the concept of a light implant, so in case you don't know what it is, a B-Lite implant is a silicone implant, and then it's I think it's 30% lighter than an equivalent sized normal silicone implant. They are now made by Polytech, which also make the polyurethane implants. They've and which is a big company, and used Polytech implants for a long time. So it's a good company, and I think the concept is very, very good, and I think the concept is sound. My view on them is that they are expensive, so that's something to consider. Your answer to your question, are there any different to put in? I saw something that someone was talking about me going on a course or something about it, but they're no different to put in at all. So they are silicone implants, the same as, you know, any other silicone implant. So there's no learning curve required. There's no, if you know how to do silicone implants, you're fine with if you know how to do silicone implants, you're fine with B-Lite implants. The technique for putting them in is the same as the technique for silicone implants. Well, they are silicone implants. So there's no difference in putting them in. They're talking to the people at Polytech, they're talking about having a polyurethane foam B-Lite implant, which will be, I think that'll be big. I think that'll be a big, that'll be yet another sort of step change, another game changer. Polyurethane foam B-Lite, which makes sense because Polytech make the polyurethane implants, Polytech make the B-Lite implants. Why not merge them? Probably be really expensive because polyurethane is more expensive than silicone. B-Lite's more expensive than polyurethane. So B-Lite polyurethane probably really expensive, but still, I guess as they get more as they get more used, maybe the prices will come down. But the concept of it, I think, is good. I think B-Lite, good concept. Yeah, is that answer? So I think it's good. And that's what I was going to say. It does depend a bit on the size you're going to use. So if you're going to use a smaller implant, 250 cc, give or take, maybe less of a thing. I think it's going to have more of a benefit for the bigger volume. So you're up onto 440 cc there. So for the bigger volumes, I think you're going to have more of a benefit with the B-Lite than with a smaller volume. Oh God, what's going on here with those questions? Jade, if you decided to have cosmetic surgery, what kind of questions would you ask in your consultation? Good, Jade. It's like you are employed to come in and ask questions. That's good question. So I would say the main things you've got to see. The main thing, I think, I will talk about the specific questions, but I think you got to get a flavor, get a feel. You can't. Well, I think the sort of gut feeling, I think it's a big thing of the whole thing, not just the surgeon, the whole place, the whole atmosphere. How you're treated. I think you got to get a rapport with the surgeon. That's why I say to people, look, there's quite a few good fully trained plastic surgeons around. So, and we all know that you've got different opinions. Don't worry about getting different opinions from other surgeons, because we all know that you'll see other opinions. And it might be you'll gel with one surgeon, but not the other, and that's okay. Go with nothing, it's your body. So that's the first thing. Get a surgeon that you feel that's going to look after you, that you feel like if you've got a problem. I mean, we had just an example. We had an extension done, and we had a couple of architects come and give a quote, and both recommended, both had done good work, both had these ideas, but one of them, they gave a plan, and we thought, oh, can't I check that plan? Just his manner made it a bit difficult for us. We were a bit frightened to say to him, what about having that wall moved a bit, into the garden, because or whatever. The principle being, his manner made it a little bit. We were a bit we didn't want to suggest a change because we thought he's quite sort of this is how it's going to be. Whereas the other one was a much softer, and it was much easier to talk to. And I thought, God, if we got into the build of this and we decided to change a wall, can you imagine it? Or we decided to put the roof somewhere else or something like that, put a window in or something like that. We don't want to feel like he's going to tell us off, it's our extension. So I think we gelled with the personality of the second one a lot more, and he was, and it was just made it nice. It made it pleasant. He would say, "Oh yeah, you could move the window. Yeah, that's a good idea." At the end of the day, it was our thing, but you don't want to feel like, and same, it's your body. You don't want to feel like you're thinking, "Oh, what about if we do lipo as well?" You don't want to feel like they're going to shout at you if you suggest, how about a bit of lipo, or actually I'm not sure if I want to have surgery, I'm going to postpone it for 6 months. You don't think, oh, I don't want to annoy him, I'll have surgery now. You got to feel like you get on with them. So I think that's number one. It's not a question, it's a feeling. I think the feeling is really important. Questions, I think it's good to look for a fully trained plastic surgeon. I talk about this a lot. If you've got someone who is or has been an NHS consultant, that is a marker of a fully trained plastic surgeon. Or if you look for FRCS Plast after their name, PLAST, that means they're fully trained in plastic surgery. If you're So nothing to do with me or anything. If you're just looking for plastic surgery anywhere, I think word of mouth recommendation is good. I think it's always good if you're, it's like same if you're looking for a builder or a plumber or anything like that. If you know someone who's had surgery with that person and they've got a good experience, I think there's a lot to be said for that. I think if you can find word of mouth recommendation, I think that's a great thing. I think it's fine. I think it's good to ask questions about people's experience, about how they've done, about different stuff like this. What have we been like mega lipo? I don't know if you think you're mega lipo, maybe that's not a good example, but mini lift, or no, that's not a good example. Actually the implants. What was the one about the implants? Different makes of implants. Anyway, just ask questions. Do your research. Just ask questions and see how they field those questions. If they're getting a bit shirty, and they're like, "Well, I use the best implants. My implants are the best, and I told you don't use those other ones." You think, "I'm flipping out. I don't want to be a bit shirty." I think anyone who is comfortable with the work and with the industry, I suppose, is happy to answer questions. If you've got questions, ask. And if I don't know, I'm like, oh crikey, I don't know. Like people have come on here and use these abbreviations. What about funny abbreviations all over the place? I can't think of them, but anyway, people use funny abbreviations, but that's okay. I'm okay if someone uses a funny abbreviation I don't know. I'm like, I don't know what that is. And if that makes me a bad person, then fine, go with another surgeon who does know what those abbreviations are. But I think it's good to ask questions and see how they handle the questions. I think it is good to you know to just see how you feel and see how they interact with you. And in terms of training experience, it's always good to ask for training experience, qualifications, things like that. Don't lose sight of that. Don't feel. And again, if you ask for the qualification, what are your qualifications? If they get shirty, again, think, oh, crikey, most people, if they're well qualified, they'll be only too happy. I'll tell you all day long about my qualifications and training and stuff, and it's good. People don't ask it very often, to be honest with you. Even though I say to everyone, you've got to ask these questions, give you a guide what to ask. People hardly ever ask me, but when they do, I'm like, oh, good. Oh, blimey, they've read my guide. Yeah, that's not really giving you many tangible questions, but yeah. Get a feeling, shop, not shop around, but it's fine to see different surgeons as well. Just get a feel for different ones. Emma's straight in here. I've got a consultation with Kuram Khan on Saturday for breast implants. Go you! I'm so excited. I'm excited too for you, Emma. Excellent. Fantastic. That's the sort of publicity we need. Debbie, when did you last refuse a patient's surgery and what was the reason why? Oh, Debbie. Oh. Refuse is a bit of a... Refuse? You know what, Debbie? What I try and do, I try not to get confrontational on it. I don't want to get confrontational on stuff and refuse people's surgery, right? I try and do it so we're on side, and I've got someone right at the moment, and I'm trying to get on side. And like, you know what? And it's usually stuff like weight, your smoke. It's usually weight, to be honest. The weight's too high. I'm like, you know what? Your weight's high, or if your weight and smoking. And I'm like, if you can't lose the weight, you're probably better off not having the surgery. And sometimes I have to say, look, I won't do the surgery. And when was the last time? As I said, I've got someone at the moment who the weight's a bit high, and we're working through that. But it's not uncommon to say, look, I think you're better off not having the surgery if you can't lose the weight or you can't stop smoking. Every month, I suppose, I don't know. So yeah, but I'm not refusing the surgery. I'm saying, look, the best treatment for you is to lose weight or to stop smoking. And if you can't do that, don't have just because I've seen problems when people have got high weight and smokers, they don't get good results. They won't be happy. I'm all about having happy patients. Now, when I say this, they may not be happy because they may think that I'm doing them a favor. That's the thing. If you do the surgery, you're not doing them a favor. They think you're doing you a favor. Oh, he's so good, I'm doing them a favor. But you're not doing them a favor. So you're not doing them a favor by doing the surgery. You're doing them a favor by saying you got to lose weight or you got to stop smoking or get yourself optimized for whatever reason. Or if you worry about expectations not being realistic, things like that. You want to get a happy result and a happy patient, rather. You don't want to upset anyone. And I'm not in the business of upsetting people and refusing them and things, but I'm in the business of doing everything I can to get a happy patient. And sometimes you'll get a happier patient by not operating on them. They may not be happy, but I just think I don't. I was going to say I don't know, because no one's got a crystal ball. They might have had surgery and been fine, but I worry that if I'd operated on them, they'd be even more unhappy than if I hadn't. So I'm always just trying to do my best to get a happy patient, and sometimes that means not operating, not uncommonly. You absolutely need to have a rapport with the surgeon, not be frightened to ask questions or fear you can't approach them. Amen to that, sister. Mine may up. Last time I asked about B-Lites, you didn't seem so sure. Wait for me, important, very helpful. All right. I'm still not that sure, Tracy, but I think their concept is good. I think the problem with them, Tracy, is they're new. That's the thing. That's why you'll find a lot of doctors are worried, sort of on the fence with them. And I think a lot of plastic surgeons are on the fence with them. Some plastic surgeons have braced them, using them left, right, and center. Some don't even want to touch them. I'm somewhere in the middle. I'm in the middle. I didn't mean confirmation for the benefit of the patient. Yeah, exactly. So but that's how I try and frame it, rather than a sort of refusal thing. I hope you don't mind the questions, as you're not my surgeon. Yeah, that I just want to make a point here that I think most people here are not my patients. This is not specifically for my patients. My patients are welcome to come and talk and post questions and stuff. But I get people, most people are not my patient. I'm not doing this specifically for my patients. My patients are welcome to, but my patients can email me directly and get in touch in other ways with me. This is because I'm doing this whole quick Q&A stuff because I am trying to, my whole thing with the clinic, and obviously I was doing all the surgery myself. I'm now sort of trying to build something bigger than me, but I'm trying to get the image of plastic surgery. It's got a bit of a bad image, really, that everyone's cowboys and no one cares, and it's just trying to improve the image of plastic surgery on a sort of more global level. I'm not trying to get anyone to have surgery or anything like that. So I just want to make the point: if you're not my patient, or if you had surgery elsewhere, or if you live in, anywhere, somewhere not anywhere near here, which is Birmingham, by the way, that's fine. That's absolutely fine. Good on you. Please ask. People say, thanks for giving. I'm desperate. Give me questions. I love it. So that's good. No, I don't mind at all that I'm not your surgeon. I'm very happy to have questions from people who I'm not their surgeon of. Although your surgeon should be the first port of call. That's the other thing I should say. Your surgeon's always your best port of call. Do the prices? Oh, what's going on here? Thanks for asking. Oh, Emma, what's going on? On the fence now. Always on the fence, Tracy. Always on the fence. Go with what your surgeon says. But yeah, B-Lites, I think the concept is good. As I've said, I got my consultation on Saturday with Kurum. 8 have had to have laparoscopic surgery 3 weeks ago. 8? Will I have to wait so long for home breast implants? Not really. 8 had to have. What's 8? Anyway, not really, because laparoscopic surgery usually bounce back pretty quickly. Depends on how you are, and if you're well, and if laparoscopic surgery went well, then and your wounds have healed, because they're usually little wounds from laparoscopic. Wouldn't have thought so. No. Jade, thank you for asking my questions. Thanks for answering them, Jade. I mean, asking them. Did I say answering them? Do your last question, people. Alarms. Do your prices vary due to the size of the mole and where the mole is? Yes, they do, and this could be extended onto tattoo. So the basically it depends on how much surgery you're going to have, but also the wound healing and the aftercare. Because if it's really tight, so I think it's in like small, medium, large. I think there's 3 prices, I think. And if it's just going to be a nice sort of direct closure and it's going to be not too tight, then that's a small, like to be honest, most moles are just most moles are small. That's just standard price. So actually, this would have probably been better for tattoo than mole, because most moles are small. Although you can get big moles. So it depends on exactly this. Oh God, I'm not answered this very well, have I? It depends on the size and the location. So basically, most moles are on the face, and the location is here where there's laxity and things. But if it's a big mole, and if it's an area where there's less laxity, like the head, the scalp, much less lax than the face. So a big mole on the scalp, more expensive, tighter, might need a couple of operations. As I say, tattoo's a better example, because tattoo and a tight, like a small tattoo on the finger would be a bigger deal than a big tattoo on the abdomen. Yeah, So yeah, anyway, it does rely on the size and the location, basically. So that's why sometimes we're a bit cagey with the mold. Say, oh, it's from, price from. You're always best sending a photo or just saying, look, I've got a small mold the size of a pea or something on my cheek. And then we go, okay, well, that's a small mole. So if you say that, then we'll just give you the price. But we're always a bit cagey. I had one once where a guy had a cyst and he has a C in treat. So he had quoted him the price. And then he came and had I think he's on the website actually, got a massive cyst here. I thought, oh my Lord alive, it's huge. There you go. Anyway, enough of my rambling. Debbie says, I'm doing a great job. I don't know any other surgeon will take time out of their busy day to answer questions. Day's not that busy, Debbie, but thank you for that. Look at me, casual man about town. But yeah, I love it, Debbie. Love it. Mad for it. Go you. You've asked. You've got in there, Debbie. So good on you. But only too happy. Only too happy. So increase the piece. Thank you for that. Nice one tonight. Same time next week. Facebook Live, 7 o'clock. Here and now. If you've got any questions, please post them. I've very much enjoyed that. And I am going to check myself out of here because I think I've got to go and pick up my little boy from school. So I am going to check out and loving all your engagement. And thank you all. Thank you all. Can I write that? Does that look naff? Thank you all. I'm just taking time to write that. Is that a smiley face? Looks a bit weird. Yes, it is. Does that come up? Anyway, it doesn't matter. Thank you all. And I'm going to check out and see you next week, Tuesday night, 7 o'clock. Any questions, please post or just do it live. Love it live. Just bring it in. I'm going to check out of here. Thank you and good night.